Top Med Talk.
Hello and welcome to Top Med Talk. I'm your host, Desiree Chappell, and I'm joined by my co-host in London, England, Editor-in-Chief of Top Med Talk, Monty Mythen. Hello, Monty. How are you?
I'm good, Desiree.
Monty, it's kind of a mixed bag today because we really probably should be in sunny San Diego for the American Association of Nurse Anesthetists. Their annual Congress this year had to pivot to virtual like most meetings. It's a huge meeting for them. Sometimes up to 5,000 delegates, I think, come to the meeting. So it's a really large meeting for us in nurse anesthesia. And I say us because I know that some of our Top Med Talk listeners probably know, but some new listeners may not know. I am a CRNA myself. And you may be asking yourself, what's a CRNA? Because this is a global podcast. A CRNA is a certified registered nurse anesthetist. So I'm a nurse trained to do anesthesia here, specifically in the U.S. I also am Vice President of Clinical Quality for Northstar, a new role that I just took on. So really interesting, all the different things that we can do in anesthesia for sure. But we pivoted as well. So when the AANA said they were going to a virtual meeting, Monty and I said, well, we'll be there right with you because that's what we do at Top Med Talk. I mean, normally we'd be in person talking to people at the meetings, talking to the key opinion leaders, the speakers, student representatives. We are doing that all virtually and we're making that happen. So that's exciting for us. And we have that opportunity to do that right now. And so without further delay, I'd like to introduce our next guest from the AANA 2020 Virtual Annual Congress. They have recorded a presentation that's going to be going out here over the course of the meeting. And they're going to be talking about prevention of emergence delirium and specifically in American veterans. And we'll be discussing best practice recommendations. So I'd like to introduce the panel today. First is Kristen Roman. Kristen, thank you so much for joining us.
Hi, thank you so much for having me today.
Yeah, so tell us a little bit about yourself, Kristen.
I'm originally from Alaska. I spent some time on the East Coast and then finally came out to California. I'm currently a student in the doctoral program in nurse anesthesia at USC in my senior year. So this is actually part of our doctoral thesis project, was looking into this topic.
Oh, fantastic. So you're almost done. When do you graduate?
May 2021.
Sweet. The end is
so
in sight. That's fantastic. Well, we're really excited to hear about this project that you guys did. So our next panelist and a colleague of yours is Jenna Bergonian. Jenna, so tell us a little bit about yourself.
My name is Jenna Bergonian. I am a student registered nurse anesthetist, also at the University of Southern California. I was born in the Philippines. I am a Canadian citizen, and I'm a proud California resident. I've been a nurse for 13 years, worked from nurse's aide to vocational nurse to associate's degree, and now I am at USC and so proud to talk to you folks.
Oh, that's fantastic. Awesome. And our last panelist is Ignacio Diaz. So Ignacio, why don't you join us?
Yeah, so I'm born and raised here in LA, 15 minutes away from USC. Always wanted to be a Trojan, so lucky and blessed to be part of this program. I'm also a third year SRNA graduating in May 2021. So thanks for having us.
Yeah, absolutely. Well, go ahead, Monty. I knew you were going to say something.
What's this Trojan thing?
Our mascot, the USC mascot's the Trojan.
Okay, for which sport?
For football.
Football, okay, that's the pointy ball football version, yeah? We got you. It's a global audience, and there's people listening from all over the world, and they'll be thinking, what is he on about? But
right.
So there we go.
Also, the globe is rolling at our eyes at us. That is enough.
Yeah, football,
so
completely
American, the local team that plays what we might call American football is called the Trojans, yeah?
Correct.
Correct. Go Trojans.
Well, just to dive right in, Kristin, can you tell us a little bit about the presentation that you guys put together based upon your doctoral thesis, what you guys did for the AANA?
Sure. The impetus for this presentation actually started when I was a nursing student. I had the opportunity to shadow a CRNA at a veterans facility out here in California. And upon emergence, our patient was swinging and very aggressive. I'd never seen anything like it. We had to obviously intervene very quickly. And the CRNA I was with said that it was really common with that patient population to have that kind of emergence. And it was so startling to me that I thought there must be some way to prevent this or help the veterans, emerge out of anesthesia so that it wasn't such a traumatic experience. So then when I went to USC and we were presented with the possibility of doing a doctoral thesis, I kind of convinced Ignacio and Jenna that this would be a great topic that might actually lend itself to helping an actual population out there that needs some good guidelines and good recommendations for treatment.
Yeah, absolutely. Well, let's take it back just a little bit and talk about emergence delirium a little bit more. Jenna, can you speak to that? Rates of emergence delirium, kind of what it is and then rates of it?
Emergence delirium is an acute phenomenon where someone basically emerges out of general anesthesia in an agitated state, in a confused state. And there's also a form of emergence delirium that can be hypoactive. So some people become very withdrawn, but for the purposes of our project, we've focused on the hyperactive kind of emergence delirium. So someone wakes up from anesthesia and they are confused and trying to pull out lines, and I'm sure that every one of us here in this panel has experienced such a thing. It's difficult to estimate the rate of emergence delirium because it's not something that has a universal definition, and also not a lot. It's very difficult to gauge how would one even survey for that on a large scale. But the qualitative estimates that we've encountered in the literature is about 30% for the American military veterans. So American CRNAs have been polled, and they say about 30% of military veterans under their care experienced emergence delirium. So I can't vouch for the accuracy, and really, truly, it's hard to quantify. And as for PTSD itself, which is a huge contributor to emergence delirium, the lifetime prevalence for civilian Americans is about 7%. The lifetime prevalence of PTSD in the military population is about 10% as opposed to the 7%. But that could be a major underestimation, and that data is from 2001, 2003, and that's quite a long time ago. So that's our best knowledge in regards to the prevalence of PTSD and emergence delirium.
For me, just anecdotally, and I haven't seen the research on this, it's always your young males who are waking up like crazy. And actually pediatric patients first. It's just they go through that excitable stage. It takes them a lot longer to come out of that. But then, in our adult population, it's like if you got a 20-year-old guy who's buff, they're going to be coming off the table unless you do something to interact.
What is this buff thing?
Strong, Monty. Come on.
Okay, gotcha.
20-year-old fit guy who, it's like the more muscle they have, the crazier they're going to be, during emergence. It's really, it's anecdotally, but that's kind of the stereotype. I hate to say it.
Staying with the anecdotes for a moment there, Desiree, do you think that's irrespective of your choice of anesthetic cocktail?
Mm-hmm. I don't know, guys, can you, Kristin, did you guys look at that? Inhalation versus TIVA?
We did, definitely. So we actually were able to break down our project into preoperative interventions that can help alleviate the symptoms, intraoperative, and then postoperative, kind of what to do after it happens if you weren't able to prevent it. So yes, we did definitely look into TIVA versus volatile. There is some recommendation for TIVA, like a propofol infusion versus volatile, but honestly, the evidence is not particularly compelling between the two. It's more choice of pre-medications that make a really big difference. Benzodiazepines tend to be a major trigger for emergence delirium, especially with PTSD. Ignacio has a really great explanation on the pathophysiology of PTSD and emergence delirium that kind of makes sense when you then start talking about the drug interactions with our anatomy and our physiology.
Yeah, well, Ignacio, tell us about that.
So kind of diving in a little bit more into what PTSD is, according to the DSM-5, PTSD is diagnosed after a patient experiences some type of traumatic event, typically, either actual or perceived risk of death or injury, or also sexual assault. Then they typically, for at least a month, have re-experiencing of that traumatic event, avoidance of that particular stimuli, anything resembling that event, and then having some hyper-responsiveness, hyper-arousal to even benign stimuli. Now, PTSD is a known trigger for emergence delirium, or at least predisposes these patients to emergence delirium. And so you have to really look at what parts of the brain that PTSD affects. So it affects the amygdalocentric neurocircuitry. This comprises the hippocampus, I'm sure you guys know, is responsible for memories. And the medial prefrontal cortex, which is responsible for like higher level of thought, behaviors, decision making, stuff like that. And then you have the amygdala, which is responsible for the sympathetic fight or flight. This is typically what you see often in traumatic events. And so it's also responsible for your feelings of anxiety and excitation. So with PTSD, you actually have this chronic release of neurotransmitters, specifically like glutamate and NMDA receptors start to overfire. And so it actually causes a reduction in size in the medial prefrontal cortex and also the hippocampus. These two structures actually have an inhibitory effect on the amygdala. And so when a patient emerges from anesthesia, you typically rely on your hippocampus as well as your medial prefrontal cortex to start, absorbing the stimuli in the OR and contextualizing it. So realizing, this is a benign stimuli, this is a benign situation. But in these patients with a reduced size of both, you actually are unable to inhibit the amygdala. And so it actually runs wild. And so these patients who are already predisposed to feeling a threat to benign stimuli, now you're waking up with not just, pain, you're waking with an ET tube, you're waking up potentially hypoxic, hypercarbic. And so this causes that hyper-aggressive state.
Sounds like one of Desiree's anesthetics there, one of Monty's anesthetics. I thought we were supposed to avoid those things, but we got a great explanation.
It was. Wow. That was a great explanation of that. Well, tell us, so this going in, and we do have a population of veterans that we're dealing with who, many more in recent years because of what's happening in the country are coming out with PTSD. So, again, I can't remember, Jenna, if you had stated this, the rate of PTSD in veterans, and then, looking at surgery wise, kind of how we start dealing with that. So, Jenna, talk about that?
I wanted to add to my previous statement that when I said that the PTSD rates among military veterans is about 10%, that is a vast overgeneralization because every war and every patient population within military veterans has their own rate of PTSD, and of course the data varies, and so that is a vast underestimation and generalization, and I apologize for that, but that is indeed the limitation of our data. So to speak more to the relationship between PTSD and emergence delirium, as Ignacio said, PTSD is a huge risk factor for emergence delirium, and there is the possibility of experiencing flashbacks along with the emergence delirium, which is a terrifying state for the patient who is also a military veteran, and also poses a danger for us as providers and for the hospital staff as a whole. And that confusion and agitation and flashback has the potential to traumatize that patient. And so something that is quote unquote a simple outpatient procedure can turn into a prolonged nightmare. And unfortunately, I have friends who have experienced that, and so which is one of the reasons why I joined Kristen and Ignacio in this project.
Wow, that's incredible. Ignacio, before we talk about the current recommendations or what you guys are recommending, Ignacio, can you speak to what currently has been being done in the VA system to help prevent emergence delirium in these types of patients and in veterans in general?
Absolutely. So my first 4 months rotating in clinical is actually at the Long Beach VA. And you get a fair amount of patients there that develop emergence delirium. And so it's pretty predominant. And right now they're trialing incorporating Ptsd pretty early on into general anesthesia. Even if you're just using inhalational agents, volatile agents, sevoflurane, whatever it may be, Ptsd infusion or pushes throughout the case. And that seems to have reduced the rates. There's also a discussion in transitioning over to TIVA for high-risk patients, identifying them pretty early on. TIVA, according to the literature, albeit not high level, there's no randomized control trials at the moment, mostly anecdotal, but there is a transition over to TIVA, and there is some positive feedback there. There's also a trial that they're doing. Dr. Alkire, one of the anesthesiologists, he's performing stellate ganglion blocks, which has been shown to reduce PTSD symptoms for up to a year. So stellate ganglion blocks are typically just regional anesthesia. However, after the reduction in sympathetic response from the amygdala because of the block lasts months, and there's actually a significant reduction in symptoms for these patients. I think it's only one of 2 VAs in the country that are doing it.
Precedex again won't translate to everyone around the world.
Sorry, dexmedetomidine.
Dexmedetomidine. Yeah, thank you.
Yeah. Wow, that's great. I did actually read something about PTSD and stellate ganglion blocks. What about ketamine infusions? Is that something that, or use of ketamine?
There's not a lot of high-level evidence to support anesthetic levels of ketamine. It's actually been shown to increase the rates. However, there are a number of articles that show sub-anesthetic levels of ketamine there is potential for reducing the rates. And so that's something that we recommend, randomized controlled trials to be performed. But there is some positive feedback, both in interviewing CRNAs and anesthesiologists that work overseas in Afghanistan and Iraq, where, this is, highly encountered emergence delirium. But they do recommend that this further be evaluated.
Yeah, for sure. Well, Kristin, can you just wrap it up for us and tell us kind of what you guys came up with at the end? What recommendations, screenings, things like that.
Great. Yeah. So definitely in the intraoperative or the preoperative period, screening is going to be a key aspect of this. There's a couple of screening tools that the military does employ. One is the Patient Health Questionnaire 9. It's the PHQ-9, and we can make that available for your watchers for sure. Another one is the State Trait Anxiety Survey, and that one is actually the most effective in the literature as far as we've seen as predicting emergence delirium for patients with PTSD. Anxiety preoperatively seems to be a very good indicator of how they will emerge. So we can make that available for your readers as well. Avoidance of benzodiazepines seems to be key also. That's preoperatively, intraoperatively, at any point in time, avoiding benzodiazepines as they tend to be a major trigger, especially avoiding them upon emergence delirium. So I think that if practitioners have a patient coming out swinging, a lot of times they want to reach for the Ativan or the midazolam, and that is proven to be one of the worst choices you can actually make because it disorients the patient further and triggers that amygdala-centric reaction even more and can actually make the emergence delirium worse. The use of dexmedetomidine is another thing. Like Ignacio said, intraoperatively as a drip or as pushes, right before emergence is found to be useful. But then also if you do have a patient waking up in an agitated state, using Precedex as that gap when you're trying to calm the patient down has been proven to be pretty effective, and really resolving the symptomology within 30 minutes and then being able to discharge the patient. So Precedex is something that we're very interested in promoting, and then also just encouraging other people to do more randomized controlled trials. Avoidance of any kind of noxious stimuli is also key. So noise, loud noises in the operating room, loud noises in the PACU is very important. We've already touched on pain, so the use of nerve blocks to avoid any kind of pain, use of opioids is also key. Trying to avoid any kind of noxious stimuli upon emergence. Having a friendly face at the bedside is also encouraged. Having someone to kind of ground that individual when they're waking up in this kind of confused in-between state can be key as well.
That's our thesis in a nutshell.
Our
elevator pitch. Sorry.
If I could, one of the things that I think Ignacio mentioned was, having an endotracheal tube in place at the time of emergence, which is very stimulating.
Noxious stimuli.
Exactly. And the question there is, I don't know where you stand on deeper extubation. I don't know where you stand on extubating to a laryngeal mask, which is much more common in Europe to avoid the coughing and gagging on the tube. And one of the things you might get from dexmedetomidine is this remarkable tolerance of an endotracheal tubing, the ability to communicate, which then goes away. You can ask people to take a deep breath and then the drug wears off and they don't remember they had the tube in. It's not like the benzo thing, which confuses the hell out of people. It's more the kind of, I'll take a breath for you if you ask nicely. Yeah. So where do we stand on that bit? That's a big question.
Yeah, Ignacio.
Go ahead, Ignacio.
Yeah, so right now the literature doesn't evaluate whether deep extubation versus awake extubation versus, an extubation with, narcotics or LTA, lidocaine. That hasn't been evaluated, so I couldn't really speak to the literature on that.
No, I was thinking the same thing though, Monty. That's what, kind of the deep extubation with the LMA is very common.
Because the work I've done has been mainly with published work I've done with PTSD in particular has been with the critically ill patient, where the incidence for patients who've been long-term critically ill of post-traumatic stress disorder is extremely disturbingly high. But it manifests itself in a different way, because I think the thing that was traumatic and to the individual, i.e. being critically ill and sedated and emergence, is probably quite different, you would suggest, to the military experience. So you can kind of see why you might end up with a different type of individual who's been through a very different experience that might associate many of the factors with emergence from anesthesia with something they may have been exposed to before, but not as an anesthetic. Crazy environments, lying down, horrible things happening. So great, really important work. Really important.
Yeah,
work.
It is. One last question before we wrap up was that you recommended dexmedetomidine. If some people don't have access to Dex in practice, and you can't get it really quickly, and if you have somebody that's kind of come off the table and you didn't realize this was actually happening, are there any other drugs that we could use that work pretty well? I mean, propofol is kind of my always go-to if I don't have anything else, and just kind of put them back down again. Let's start the whole thing. Let's start emergence all over again, kind of thing. Were there any other recommendations there?
I think propofol is anecdotally going to be the second choice for people to kind of reawaken the patient with in a better environment with a less noxious stimuli if you can, coaching them slowly awake, and you might have a better chance with that if you do put them back to sleep with the propofol.
Yeah. Okay. Cool. All right, guys, wonderful work. Wow, this is really fascinating, and I'm so glad that you're doing it. It's much needed.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.